I mean, that was a pretty sobering call you just made. But I think our next presenter is going to tell us with machine learning and incorporating this gigantic tool in many aspects of life, not just in data mining for risk prediction. There can be some new hopes and new grounds. Without further ado, I'll give you Dr. Kakadiaris.
All right, so good afternoon, everybody. It's a real pleasure to be here, to see old friends and make new friends. Dr. Fuster, thank you for the challenge. You invalidate my whole talk, but that's okay. I take the challenge of how we can take this work of what I was planning to do today, give you a short primer on what is machine learning and how I think it can disrupt survival analysis and make me think how machine learning can disrupt the educational paradigm. Thank you for the challenge, Dr. Fuster. But before we proceed further, let's go down the memory lane and let's see if you remember this. Of course, Mort gave it out, so it will be easy for you. You can start the video.
Romantic Russian composed Etude Tableau for piano. Watson, who is Rachmaninoff? Rachmaninoff is correct, and that adds to your lead. You're at 13,400.
And not only that, but a few months ago in March 2016, you can see that the DeepMind artificial intelligence system basically was used to win the final match in the Go series against the world champion. So there's a lot of buzz around about artificial intelligence, correct? In IBM, I guess they like to say it as automated intelligence. So what is artificial intelligence? In a nutshell, artificial intelligence is the science of developing intelligent machines, and it attempts to improve or mimic the cognitive functions that humans perform, such as learning and solving. And a branch of artificial intelligence is machine learning. And machine learning, what strives to do is to improve performance through experience, data, and learning. So basically, it's a method for teaching computers to make predictions based on data. Notice the key word there, data. I really like this cartoon that basically demonstrates the idea that our algorithm becomes better as we get more and more data, and this is what Dr. Fuster talked about. It's not, machine learning is not to be confused with statistics. It's two different disciplines. Machine learning, you are dealing with high-dimensional data, more than 100 dimensions, and you are looking to find structure in domains where a simple statistical model will not be adequate. You're trying to model domains where you have complicated underlying structure. If you are wondering if you use machine learning, I will tell you that your email provider already uses machine learning for spam filtering. If you follow the recommendations of Netflix for watching a movie, then you have been a beneficiary of machine learning. Whether you check the forecast today about the amount of rainfall, that's another area. But let's see how this works. Let's think of a specific problem. Okay? We have data and we have labels, the prediction outcome. Then the technologists will develop features and will train a model. But let's be a little bit specific. Suppose I want to find out and develop a trained model that will tell me if a specific email is spam or not. How do I go about it? Well, I have to give a lot of examples, but not only examples, but the labels. So I give an example email, and I give the label spam or not spam. And based on this information, I can develop a trained model. Once I have this trained model, when I have a new datum, then I can give you the same prediction. So emails arrive into your email provider, the trained model is used to decide whether this is spam or not, and then send it to your inbox or to your junk filter. I know maybe I'm getting too much into details, but there are actually 4 types of machine learning that I want you to be aware. The spam filtering is what is called supervised machine learning. The idea there is you have data and you have the labels. You have data which set the emails and labels whether it's spam or not. But there is also the unsupervised machine learning. For example, suppose that you want to find out what are the most common tweets. You can use unsupervised machine learning to cluster these areas. Or in some examples, in some cases, you have examples where you have labels. Let's say that you have some city exams where you have the labels about classification, but you have exams where you don't have these labels. Then you can call it semi-supervised machine learning. And my favorite example is reinforcement learning, which is basically learn a policy that will help us improve the outcome. And I don't know if you have seen this movie about teaching robots to walk. I'll play it just for your benefit.
Okay, so in the beginning it's going to look hopeless, but I promise you it gets better. And just to be clear, this is the skeleton of the robot. And so this is not a human animator going there and just moving or animating this video. This is really the robot, the algorithm, choosing which moves to make by moving the joints of the skeleton that you're seeing. And you can see it's already getting better. Now suddenly the robot's able to walk.
So what I'm doing is I'm giving a positive reinforcement if the robot does not fall, or a negative reinforcement if I'm going away from my goal. You may ask, why machine learning now? Well, I don't need to tell you about the abundance of data, correct? In 2013, we had 4.4 zettabytes, and in 2020, we have 44 zettabytes. If you are not familiar with the term zettabyte, I'm sure all of you are familiar with the term gigabyte. So if you take 1 trillion gigabytes, you have 1 zettabyte. So that means in 2020, we'll have 44 trillion gigabytes. That's a lot of data to go through, no matter where you are in the ecosystem. And now you know about Moore's law and the growth of computing power. So we have the computing power to go through this data. So these are the technological advances that allow us to make progress in machine learning. So there are great opportunities here in the whole ecosystem of health, wellness, and healthcare, both for patients, physicians, hospitals, and companies. And I truly agree, and I'm really thankful for Dr. Fuster's message, but it's not only education, it's not only research, but it's also the educational component that we tend to neglect. So if we focus right now a little bit on survival analysis and the clinical care, so you as physicians, you have a deluge of information at your disposal, correct? You have family history of the individual, physical tests, cognitive tests, imaging tests, results of various omics, and at the end, you have to provide clinical care. So for me, it's actionable information. You need from data to come up with actionable information, and this is what, I'll skip this slide, that's what machine learning can provide for you. It allows you from this deluge of input to provide options for either survival analysis or for clinical care. So you can think of it as input-output. So let's talk a little bit from the work that Dr. Nagavi and Dr. Budov are doing together on predicting the 10-year risk of an event. Okay, I'm not going to tell you about MESA. You're all familiar with MESA and the types of events we have in MESA. You're all familiar with specificity. If we look at CVD, specificity, if we look at coronary heart disease. And the idea is, for me, the outsider, I'm just a computer scientist, the question is, can we do better? Can we improve specificity? And the answer is, Well, let's try to cast a problem as predicting an event. So on the left-hand side, we'll use all the attributes that are used in existing calculators, and on the right-hand side, we'll say event or no event. Well, if we do something like that, and I'll skip all the details, you can see that you can get 100% specificity for CVD, and 100%, and the net reclassification index is about 36%. You can do the same if you add calcium score. Remember, we're not changing the attributes. We're just changing the recipe. The ML, the machine learning is the recipe that you use these attributes. And then again, you can get 100%, and with the net reclassification index 20%. Why is this important? For me, it's important because of all the discussion that we saw recently for statin therapy, and what we can see as an outcome of our work. You can see the reclassification of individuals that they are not in need of statin therapy, and we can talk more about it later. Actually, we have a website where you can upload the data that you have from your study, and you can get the numbers that our machine learning algorithm will provide to you, or check individual cases, and I'll be happy to give you this website later. This was the first test, correct? Very simple attributes. Can we do better? And I know some of you are looking to see what information can you get from the coronary calcifications. Can we get information that will help us discriminate between vulnerable versus stable calcification? This is the kind of information that the machine learning algorithm will be able to help and tell you what are the features that add predictive value. And actually, you can think of all these new parameters that you have from your assessments of the individual and see how this will impact the survival. And again, where is education? We need to add education, I think, there. One of the challenges that one becomes quickly accustomed when you work in this domain is that the low number of events. And of course, low number of events is a good thing, but for computer science, that's a problem because it creates what is called unbalanced data sets. You don't have equal number of examples for positive and negative class. So in computer science speak, we had to develop computer science algorithms will augment the data set, will augment the events, so we can obtain meaningful results. So if you ask me what we need, I think we need data, and large amounts of data. So for a computer scientist like me, the idea of creating a national research cohort by collating data from different studies, it will be definitely empower getting more meaningful results. And with that, I'll stop and I'll get any questions that you may have.
I'd like to add here one point that I watched Ioannis and his fellows doing this machine learning. When Matt Buddha brought the first set of MESA data, the predictive value, the net reclassification sensitivity was significantly lower than the most recent MESA data, just by adding a little bit more of MESA. Now imagine if you have all of these other cohorts added to this, the significance of the improvement can be significantly higher. Please go ahead.
Thanks for an excellent discussion. I'm learning. I had to Google machine learning before I came here to better prepare myself. That if I heard you correctly, you said you're enhancing specificity. I didn't hear you say the word sensitivity, and I think for detection, isn't that a little bit more what we're interested in?
So we are enhancing both as evidenced by the net reclassification index. I just focused on specificity because I wanted to make the point about people that are statin eligible versus statin non-eligible. We'll be happy to share the paper. We're enhancing both.
But we have less power when you have a small number of cases, because you said the specificity was very high because you have a lot of non-event that you teach
Indeed.
your machine learning to learn from that many.
Thank you. That's a good point. Yes, sir.
Mike, so to be sure I heard you right, you say that the model at 100% specificity? Is that correct? In the sense that they can
So,
perfectly predict non-events.
so let me tell you how we came up with that, okay? So the idea is we took Mesa and we did leave one out. So we learned with all the cases except one, and we were able to predict in all the cases correctly.
Sorry, just flesh that out again. You're able to predict, say that again, predict what exactly?
Whether we'll have event or no event,
Perfect.
the specificity.
So, if I'm familiar with specificity from an epidemiology point of view, would be non-events, the correct prediction of non-events. So you identify perfectly the non-events.
That is correct.
Yeah, that was my first
So I'm trying to
shocking, shocking, question that,
It's either you can predict perfectly non-events,
Okay, so-
therefore you predict perfectly the events too.
well, no, that he needs about 3,600 events in order to reach that kind of predictive power. Because he has a lot of non-events, he kept feeding the machine
Right.
with this method of take one patient out, reach. It wasn't 100% at the beginning, and it kept
But
feeding.
you're to say that you can, the model, like apparently can say, this person will definitely not have that.
Within 10
In the time
years.
range.
Yeah.
Within
In the time range that we have Mesa events. Okay, we're limited by the information provided by the examples, correct? So the Mesa events are in a 10-year period. So what we are saying, whether you have an event or not in the 10-year period. That's not 1 year. Really?
Is, as I understand it, it's the machine that is learning something. I'm not learning anything. But it's a problem, because if I don't understand the disease, if I don't understand the output in some way, how can I treat it? Well, I can treat increased risk non-specifically, but I cannot treat the cause of the increased risk. I don't know what's going on. The machine is learning, I'm not learning anything because I don't know how you get to the result.
So that's an excellent point, Erling. So if you look at this here, using what machine has learned, we'll be able to find out what are the important attributes from all this deluge of data that will help us understand the biology of the disease.
How can it help us understand biology if we don't know what's going on?
So of course, it's limited by, I'm not going to tell you that I'm going to invent new biology, but my answer is, from all this input, we'll be able to tell you which factors are most important than others. A rank ordering of the factors, okay? The machine cannot go beyond the factors that you have in your input. What can tell you is what is the relevant importance of the factors. So we're not discovering the mechanism. We're discovering the importance of features.
Yeah. Because you also say you can use it to find a new therapeutic target, and you want to find that you need to know what is mediating or causing the increased risk.
So I will argue that you can think of it as understanding what are the features that can be the source of new hypothesis testing. I will argue that, again, as an outsider, not a leader scientist, that if you find the relative importance of different attributes, that will allow you for new hypothesis testing using all the scientific methodologies that we are familiar with.
But do you know what's going on in the machine? Do you know that?
Yes, actually you can convert the trained model, you convert it to a number of rules. And in our case, about 200 rules. So yes, you can convert it as a set of rules. But why does IBM call it automated intelligence? Because it's a task that requires you to digest 200 rules, and you don't want to go through 200 rules if you want to come up with this.
But when the machine is learning, it is changing the rules the whole time, isn't it?
No, you are learning based on the set of data, and if you add additional data, the rules are changing.
Yeah. So it's changing constantly.
Well, depends on your update, correct? Right now we have fixed it for Mesa, but maybe we want to apply the same training model to Framingham heart study. We're not changing the rules. We say how these rules are performing in a new therapy. But learning constantly actually is not a bad thing. You want to learn constantly. because you want to build anti-fragility, you want to build muscle. By learning constantly, you are improving the rules.
Yes, but who is, I just say, what do I learn? The machine is learning, what do I learn?
That's up to you.
Uh,
Ioannis, I have a question. Yeah, on the augmented data set, what is that? How do you get those? What does that
So
mean?
basically, we developed a computer science method that allows you to create additional events by taking, we are creating imaginary patients that have events, and we can use them to offer training examples. These are completely synthetic examples, but this technology improved the NRI that we have there.
Since this is an iterative process with the same data set, what extent are you just overfitting to your own model, in terms of generalizability outside that?
So that's a very valid question, and these results should be taken with a grain of salt because this is just 6,000 individuals, correct? So if you ask me, I would like to see the results when we'll have 20 million individuals. I'm not here to tell you that we invented the next thing after the sliced bread. I'm here to tell you that if we have more data, I think we'll be able to see if these ideas hold any water or not.
Actually, that website that Ioannis showed, created for us as we move forward in our project. Though our project focuses on 1-year event and a lot of other data to come in, but meanwhile, we can use the tool that he developed. Upload, I was talking to Samir and talked to Dr. Fusser. They have quite a few of these larger studies. They can feed and see how it performs in their data set, in your data set. And so we both evaluate, also feed. You saw the robot that was falling. He didn't show all the movie. The beginning was awful. This robot was just falling left and right. But by the time it reached 600 reach ratio, which is a lot of computer work, it was almost running. So hopefully his machine learning will run as we these new data.
So I can bring all my data from all my buddies into that program?
Yeah, no problem.
Yeah, so obviously it has to be adjudicated.
So thinking about, the future application getting to the patient or the physician with this ability to predict events, this is based on a huge amount of data, which is not going to be available clinically, even if it may outperform the pooled cohorts equation. So how do you go from however many bits of data that you have, this large amounts of data, to how do you boil it down to a clinically useful model?
Okay, so
This is based on Framingham risk factor only.
Only?
Only.
I'm sorry, I thought it was based on the MESA data.
no. So let me repeat that point because I think it's very important. We're not proposing any new attributes or new risk factors, correct? Saying, take your favorite calculator, use exactly the same attributes, the same factors, and we're just changing the cooking recipe.
Sorry, you're changing the what?
The cooking recipe.
Oh.
It's like when you're making a plate, correct? You give me the same ingredients, but I change the cooking recipe, and I get a different plate. Also, let me tell you another thing, and allow me to get into jargon. It's called learning using privileged information. When I'm learning, I can use 1,000 attributes, but when I see a patient in front of me, I know only 10. There is a way in computer science where you can take advantage of all the vast information that you have for learning, but when the patient is presenting to you, you can use only a subset. That's some of the latest advances in computer science that we can take advantage. But here is just established risk factors. And you can put us to the test. You can submit a test where you know the data set where you know the answer, and we'll do the prediction and you can do the validation on your own.